get that they would like to hear a recording. All right. Well, good morning, everyone. My name is Annette Marcus. I use she, her pronouns, and I work with the Oregon Alliance to Prevent Suicide as their suicide prevention policy manager. And the Alliance lives inside of the Association of Oregon Community Mental Health Programs, which is a statewide trade organization that represents all the community mental health programs across the state. And one of the things that's been really nice about being part of that organization is it means that once a month I get to be in meetings with the directors of the local mental health authorities across the state and hear about the real complexity of implementing effective behavioral health work and the kind of myriad of challenges that they face, but also the incredible deep commitment they have to really make a difference for people in need. Today, I'm excited to be talking about the new national framework for suicide prevention, and I hope to just explore a little bit with you about what it might mean for all of us who work together. And I just want to say at the outfront that I am approaching this knowing that I'm talking to a group, many of you are experts already in this field, and I want us to be thinking about what does this mean for our work? How do we take these big national broad concepts and apply them to the work that we're doing here in California? Next slide.
In Oregon.
Oh God, that was a flashback to 12 years. I've lived in Oregon a long time now. Thank you.
You're just keeping us on our toes, Annette. Just
That's
making
right.
sure that we're with you, right?
That's right. And I actually wanted to go through and read to you the dedication to the national strategy, because I thought, really, this is a dedication to all of us. To those we have lost to suicide, to those who struggle with thoughts of suicide, to those who've made it, to those caring for someone who struggled with thoughts of suicide, to those left behind after a death by suicide, to those in recovery, and to all those who work tirelessly to prevent suicide and suicide attempts in our nation every day. We believe that we can and we will make a difference. That's how they started the national framework, and I really appreciated them landing it so much in the lived experience of those of us who care so much about this issue. And I chose this picture because I think this is a road, and it could either be a road to a sunset or a road to a sunrise. And I think the work that we do helps us to orient to the sunrise so people can have hope and move forward with their lives. Next slide. Before we dive into the details of the new national plan, one of the themes of the plan, not surprisingly, is addressing the issue of isolation and lack of connection between individuals. And one of the things I really believe in as somebody who does suicide prevention work is the power of kind of parallel practice of the way that we work together, demonstrating the beliefs that we have about the kinds of changes that need to occur for our society to become one where people no longer feel the need to leave, to end their lives because of hopelessness and despair. And one of the ways we can do that, even in our disconnected world of all being in virtual spaces together, is by actually occasionally having real conversations and just human connection with each other. And so just to start, wanted to give everyone here a chance to connect with each other a little bit. We're going to break you into groups of 3 and ask you to choose one of these protective factors up here. These are protective factors that have been identified that are protective for suicide. Choose one of these and talk about how they show up in your life, in your workplace, in your home. Where do you see these happening? And of course, introduce yourself to each other. And we'll take about 5 minutes in small breakout groups to just reflect a little bit on protective factors. And my colleague, Jen Fraga, who is the coordinator of the Oregon Alliance to Prevent Suicide and does just incredible work to support everything we do in so many ways will split us up into these different groups.
Annette, do you want to be in a group?
I think I will stay out of a group today.
Perfect, because then we'll have perfect groups of 3 with that. Just one moment, folks, just to make sure that these are going to work. 6. There you go. And everybody's back in it.
Great. Well, welcome back, everyone. Glad you got a chance to connect with each other a little bit and reflect on protective factors. Anything that struck you from the conversation that you want to share back with the larger group, or anything you want to share out? Okay, we'll go to the next slide. So I was really excited when I saw that they were releasing a new national framework for suicide prevention, and curious about how and if it would be any different from previous kind of iterations. And a lot of the language will look familiar to those of you who've spent time with the national framework at all. But there is a new emphasis within the new framework around health disparities and equity. And I want to just share what I see as really the major cross-cutting themes throughout the document. First is that they've done a really nice job of centering perspectives of those with what they call suicide-centered lived experience, which for me was a new phrase, a new way of saying people with lived experience of either a suicide attempt or suicide loss. Across every single one of the goals and objectives within the national framework, they look at health inequities and social determinants of health. They really talk about reducing access to lethal means as a fundamental strategy for reducing suicide loss. They emphasize a cross-sector approach, and I didn't put a lot of details in this presentation about it, but there's actually a lot of details about how different federal branches of government and different pieces, bureaus, et cetera, are working together on the issue of suicide. And one of the takeaways that I have from that is how much God, I don't know where I'm in California, how much in Oregon we have started to do some of this cross-sector collaboration. For example, I see collaboration happening between the Oregon Department of Education and the Oregon Health Authority. I have seen reaching out to the forestry department for work, but I think we have further we can go in terms of really thinking about what does it mean to address suicide in all the different spaces where we could be impacting people's lives and lifting them up, allowing them to know where they can find help, and giving them some strategies for getting through tough times. Another theme throughout the report is the importance of not just addressing death by suicide, but also addressing suicidal thoughts and attempts by suicide. And I think that's something I've heard individually from a number of members of the Alliance, is that sometimes they feel like there's so much focus on the people who die that we can forget about the folks who really are struggling to stay with us. And that we want to really be sure that we're finding ways to lift up and embrace those who may have made a suicide attempt, because we know that most of them will survive and live the rest of their lives, and we want to increase the number of them that will have that outcome. And finally, there's an emphasis on the importance of ongoing research and monitoring. there's 3 documents that I think are really interesting. And if you want to geek out at all around this work and really learn more about it, I think taking a look at these, and these are all issued by the Surgeon General. And there's something very powerful about a Surgeon General's advisory. That's the kind of highest position of the medical profession in our country. And they really are in a position to make calls to action. And the 3 areas that connect to this work that they have issued advisories around in the past few years. The first has been around the crisis in youth mental health and protecting youth mental health. The second, and I'm very moved by this one, is looking at our epidemic of loneliness, really talking about how social isolation is hurting folks, not just in terms of loss to suicide, but increase of substance abuse and a whole array of negative health outcomes. And then the third most recent advisory was an advisory on social media and youth mental health. And we won't go in depth into any of these advisories today, but I think they're good resources for those of us working in this field to look at and think about as we're trying to position our work, and also as we talk to funders about funding our work. Next slide. I'm starting with a few statistics and pieces of data. These are all national data. This is the map of the United States, states by residents, and the rates per 100,000 for the United States of suicide. And unfortunately, we see that Oregon remains one of the highest in the nation, although we have moved from the very, very highest ones, which are Idaho, Montana, and North Dakota, down to that sort of second tier, which includes Oregon, Nevada, Arizona, Kansas, Iowa, Missouri, Arkansas, Kentucky, West Virginia, and Vermont. There's a lot of debates about why and the rates vary so much across the country. But I think that one of the lessons that I take from this is I want to look to some of the folks who are in that lower rate of suicide risk: California, Illinois, New York, Massachusetts, Connecticut, Rhode Island, New Jersey, Delaware, Maryland, and really take a look at how they are addressing suicide and moving the work forward. And I thank you, Jill Baker from the Oregon Health Authority, who's the Youth Suicide Prevention Coordinator, pointed out in the chat that all of the darkest states in here are amongst the highest rates, and 3 got listed in this. I didn't do a good cross-check between those 2 pieces of data, so thank you for catching that, Jill. Next slide. The report also includes some reflection on the intersections of age, race, and ethnicity between 2018 and 2021 in suicide rates. These are the rates of increase during that time period. So the rates increased 36.6% and 22.9% among non-Hispanic, Black, or African American populations, ages 10 to 24 and 25 to 44 years, respectively. I had to read that a couple of times to understand that means that there has been an increase for Black and African American 10 to 24-year-olds by 36% in that short period of time, and by almost 23% for 25 to 44-year-olds, which tells me that our young Black and African Americans are struggling in new ways, because historically those communities had lower suicide rates than other communities. So it really leads us, I would think, to some soul searching and really to having some deep kind of reflection on how we do suicide prevention work that addresses the social determinants of health that are so negatively impacting this population. Another group that has historically had a high suicide rate, but continued to have a growing suicide rate was non-Hispanic, American Indian, and Alaska Native populations ages 25 to 44, in which there was a 33.7% increase. I think this is new data, which is data around multiracial folks. And Oregon has an awful lot of people who are multiracial, and there was a 20.6% increase for the ages 25 to 44. Amongst Hispanic populations, also amongst 25 to 44-year-olds, there was a 19.4% increase. And suicide rates among females and males continue to show large differences. Male age-adjusted suicide rates were about fourfold higher than female rates. Next slide. So they also have shared data on suicide thoughts and attempts, and I appreciated that the report includes sort of a disclaimer at the beginning that says many more people think about and or attempt suicide than those who die by suicide. And most people who think about or attempt suicide never go on to die by suicide. I think that's a very important message for us as we work to combat stigma around talking about suicide, and also allowing people to tell in very real ways about the struggles they have gone through around attempts and helping them to see kind of a pathway to hope to their lives being different. However, in 2022, 13.2 million adults reported seriously considering suicide, and 1.6 million adults reported actually making a suicide attempt, according to SAMHSA. And this is kind of shocking to me. 2021, 30% of female high school students and 14% of male students reported serious thoughts of suicide. Rates range from 18% among non-Hispanic Asian students to 27% among non-Hispanic American Indian, Alaska Native students. 58% of students with any same-sex sexual contacts and 45% of lesbian, gay, bisexual, questioning, or other non-heterosexual identity reported serious thoughts of suicide, compared with 15% of heterosexual students. Next slide. So those are all pieces of national data, and I want to let everyone know that you'll have an opportunity to learn much more in depth about Oregon's latest data on June 26th at 1 p.m. Taylor Chambers and Megan Crane from the Oregon Health Authority will be giving a webinar presentation. And I believe the presentation will be primarily focused on youth and young adult statistics, but they will include some of the broader statistics for the state. And I think it will be really grounding for all of us doing this work to hear what the statistics look like for 2023. Or Jill, is that 2022 that they're reporting on now? I get a little lost in the data.
Yeah, it's
2022.
finalized 2022 and preliminary broad strokes for 2023.
Great, thank you. Next slide. So I was looking to hear a little bit from our national partners and ran across this introduction to a luncheon they actually had at the White House that had quite a few prominent people at it, that was conducted at the launch of the framework. And at the launch, U.S. Surgeon General Vivek Murthy provided an introduction to three panelists. And I was struck by the fact that he took the time to share how suicide had touched his life and why he thinks this work is so important. And I think that's really amazing modeling from a national leader, and want to just give us a moment to hear from the Surgeon General. So, and Jen, the place where this video, and you can stop this video, is right after he mentions sources of strength.
Okay, let me just pull it up. Just give me a couple of seconds.
Thank you, James, for that resource around Black youth suicide prevention.
Okay, so when I hit play, if y'all could give me just a thumbs up and like the emojis, or if you want to use your real life thumbs, it's also totally fine to let me know if you can hear the sound. And then once he mentions sources of strength, I will end the video.
And I'm going to introduce you in a second. Why don't you come have a seat? Go ahead, Ashley. Hi, everyone. How's everyone doing?
Jenny can barely hear it.
It's good to see all of you here today. I'm so happy and just honored to be joined.
Yeah, I'm not sure. The sound is all the way up on the video itself, and mine is also all the way up. So it may, on your end, okay. It is quiet for me too, even though it's all the way up. So I don't know what's up. I don't know why, but.
And by three people I deeply admire, by Ashley Judd, an advocate and an actress, by Shelby Rowe, who has been leading suicide prevention efforts in communities and helped inform this product, actually, that we announced today, the National Suicide Plan. I also want to welcome Aloe Black, who is a songwriter, a musician. We had an argument about whether he's a scientist or not. I think he is one. Certainly trained in, in science. He's invested in scientific ventures that are helping to advance prevention and treatment. These are three incredible individuals in their own rights, but who also come to this conversation with something that many of us in this room come with, which is stories, lived experience, a connection, a personal connection to the topic of today, which is suicide. I'll say when I was coming over to this event, I was thinking about my uncle, who we lost to suicide when I was in high school. I was the first one to learn about his loss, the first one to pick up the phone and speak to his roommate, who told us that he had in fact taken his own life on that day. But at that time, I was a junior in high school. I didn't know who to call. I didn't know how to think about this. I don't know if it was my family's fault because we missed certain signs. I didn't know what to do with the shame that we all felt around the fact that this happened to someone in our family. I didn't know what to do about any of that. And my family was confused, and it was a time of great pain. And I think that many of us who are here today, and who may be listening from afar, also come to this not just as individuals and as advocates, but as people with stories, as people carrying our loved ones on our shoulders, perhaps people we have lost or nearly lost. And that's a heavy weight to carry. It reminds me of this beautiful poem that I once had the privilege of reading at a wedding by E.E. Cummings that starts with the first line that says, "I carry your heart, I carry it in my heart." And that it describes, I think, how so many of us carry the weight of what we've gone through, of what we've seen and witnessed in our own lives, in our families, in our communities. We carry those lives, we carry those stories in our heart. And sometimes that weight can be heavy. But here we're here together for a reason, which is that we don't have to carry that weight alone. And that from a government standpoint, we want to do everything we can to make sure that we are preventing suicide whenever possible and supporting those who may be left behind or who may be survivors. But I also want to just underscore what Ashley and Shelby and Alla will help us do, which is to recognize that there's great power in sharing our own stories with one another, that we can be sources of strength for each other. And so I want to start this
Is
conversation.
that the sources that
actually
you were
about-
mentioning? I was thinking that he was going to mention the Sources of Strength program in Oregon, and I was like, well, that's pretty freaking cool, but that makes more sense.
No, I like it that he used the phrase sources of strength. I think it speaks to the way our programming kind of infiltrates itself into the language of our culture. I think it's easy to undersell the impact of national leaders stepping in and really naming suicide prevention as a public health issue and naming the way it has touched their lives and saying this is a national priority for government. And one of the things I see for all of us as suicide prevention advocates is the need to keep Oregon, which has done a good job in many ways in the last few years in prioritizing suicide prevention, but to continue this message forward of this is a public health crisis that we all need to lean in together to make a difference on. Next slide. An important piece that I'm going to be very interested to see about the new plan is that they, for the first time, they've come up with a federal action plan, which will be implemented over the next 3 years. And there's going to be some strong strategy monitoring and evaluation. And one of the things that is happening nationally is that there's beginning to be a real definition of what are the core suicide prevention metrics to assess both short-term and long-term progress. And I think that we should all keep an eye on that as we're measuring how our programs are doing, how the work we're doing here in Oregon is occurring, so we can begin to line up the work that we're doing with these metrics and learn about how to continue to improve our work. Longer term indicators will be monitored by the Action Alliance for Suicide Prevention in collaboration with the federal government. And those two organizations are really the joint stewards of the national strategy. Next slide. And just to reiterate around national data points, suicide rates increased 12.7% from 2012 to 2022. After with some small declines from 2019 to 2022, to 2020, it's been disappointing to see the rates climb again post 2020. 132 people die each day by suicide in the US, which is almost one person every 11 minutes. More than 49,000 people died by suicide in the US in 2022. And as we mentioned earlier, 1.6 million people attempted suicide and 13.2 million reported seriously considering suicide. Because I know so many of you are actually out there doing the work of suicide prevention, sharing stories about suicide prevention, just a reminder that as we do suicide prevention messaging, it's really easy to go down kind of the rabbit hole of grim statistics. And it's important for us to find ways to balance that, to make the contrast for programs of hope and resilience in all the many ways that we as a community are working together to change these statistics. So for nationally, one statistic that I pulled out that I see as a statistic of hope is that there were almost 5 million calls between July 22 and May 23 to the national hotline, to the 988. And that was really just in the first year of implementing a brand new program across the state. I see David Westbrook is on here. I don't know, David, if you have off the top of your head how many calls Lines for Life got in the last year.
I don't, but I'll pull it and put it in the chat while we're doing this meeting.
That would be awesome. And I think as we are sharing out information about suicide prevention, it's really important to continue to talk with people about options and ways that we are successfully intervening and helping people to make the choice to continue to live. Next slide. So the national plan is really organized around 4 strategic directions. And the first one is around community-based suicide prevention. And I'm going to walk through each goal and ask for you all to either say out loud or put in the chat something that you know is happening in the state of Oregon that might fit with this goal area. So, goal 1, establish effective, broad-based, collaborative, and sustainable suicide prevention partnerships. Can folks think of any of those efforts happening in the state?
I can. I was in the Nine Tribes Quarterly meeting before I came to this one, but it was hard to hear there, so I told them I was leaving, but I'll be back this afternoon. But they are working together in trying to set up a postvention in their communities. So Warm Springs has a mobile crisis response, and that's what they're trying to start in the other tribal communities. So they're working together and creating that.
Thanks, Rosanna. That's such a powerful example of it. And I think that probably most of us are involved with some level of cross-sector, broad-based work. Certainly the Oregon Alliance is one of those efforts as well. And just seeing you all here is part of building that kind of community. What about supporting upstream comprehensive community-based suicide prevention? Think about prevention and postvention in schools, small steps program, a broad-based sources of strength. Great. How about reducing access to lethal means among people at risk? I have to call out Donna Marie Drucker and the, oh no, Donna Marie, I'm not going to say the name of your organization correctly, but it's
That's
basically.
okay. We can call it the California. No, I'm kidding.
No.
We have, yeah, handing out lock boxes. The state is doing so much amazing work here by providing grants, each like suicide prevention coalitions, providing secure storage. I know like Deschutes County is doing a lot of great work. I know Dell's doing a lot of great work. One of the things that we're kind of excited about, Clackamas County just got a blueprint grant with our coalition. And with that, we're going to be providing education to kids and their family members about why you don't touch firearms, how you get an adult, why firearms should be securely stored. So we're really targeting homes with youth in them and then providing those parents with secure storage devices to make sure all their firearms, including that self-defense firearm, is secured. And that's, I could talk for a long time. There's a lot of stuff happening, but I won't take up the space, but a lot of stuff happening.
That's great, Donna Marie. And this is very much just a couple of quick headlines from around the state, but I think it's important that we see ourselves in this national plan and think about how it is that we are building up really the national infrastructure to prevent suicide. Goal number 4, conduct postvention and support people with suicide-centered lived experience. And certainly Rosanna spoke about work that the tribes are doing in this area. In this one, suicide rapid response, that is a response to communities that have been overwhelmed by youth suicide. All the local coalitions are working around postvention. And Oregon remains one of only 2 states in the country that actually have legislation in place around developing postvention plans and supports after a youth or young adult suicide. Goal 5, integrating suicide prevention into the culture of the workplace and into other community settings. Can folks think of a couple of examples of that in Oregon? QPR trainings, school-wide trainings. The Construction Suicide Prevention Project out of Lines for Life is one of the things that I thought about. It's a powerful coalition of people in the construction industry who have really committed to working together to end suicide. And it's very important work, because if you look at the various occupations and rates of suicide, folks in the construction industry have the highest suicide rate in the United States. And so doing very specific work in that community is important. I saw that Erin Porter is here, and I know that Erin recently implemented at her CCO a program called the Small Steps Program, which is something we developed out of the Oregon Alliance to Prevent Suicide. And Small Steps is a program to provide resources and education in the workplace to people about suicide prevention. And if folks want to, they can also invite in the American Foundation for Suicide Prevention to present a short training to the workforce that is designed especially for that. Goal 6, build and sustain suicide prevention infrastructure at the state, tribal, local, and territorial levels. I think this is an area that we as advocates need to continue to work to increase and move forward. But I think of many examples around the state for doing that work. A recent one is the investment that the Oregon Health Authority made in supporting local coalitions that are doing suicide prevention work with small grants of just $20,000 each. And at this point, there are 20 different coalitions across the state that have gotten these small $20,000 grants. And they are doing things ranging from working about lethal means access to really creative programs around addressing suicide with Black youth. There's in Eastern Oregon, there's a coalition that is focused on really supporting and amplifying positive messages for LGBTQ youth. And many of the coalitions are bringing out the evidence-based trainings in a lot of different ways into their community. It's an example of how investment needs to go from the federal level to the state level and move out into our local communities, and that each level needs investment. The 7th goal in this area is implementation of research-informed suicide prevention communication activities in diverse populations using best practices from communication science, which is a really long way of saying, let's find ways to communicate our messages around suicide prevention in communities in ways that match those communities' needs, those communities' ways of talking to each other. And I've been really excited to see Dean Carson over at the Oregon Health Authority, who is the communications person they have in charge of the rollout of 988. And he has just been so thoughtful in his conversations with people and coming to speak with folks and listen to a lot of different perspectives, which makes me hopeful about the kind of 988 messaging campaign that the state of Oregon will have rolling out. We haven't seen it yet, but I'm hoping that it will be responsive and thoughtful about reaching many different communities and using different avenues to reach communities. I think one of the key learnings really from the whole COVID epidemic was how important having trusted messengers is in communities, so that sometimes having something that comes from a government agency is not the best way to communicate really important information. Finding an elder within a community, finding somebody in a community who is trusted by other people in that community makes a huge difference. And as we are building our coalition and our field across the state of suicide prevention, keep an eye out for people who can be those trusted messengers, who community members know when they say something, it matters. When that person talks about about making something happen. You can trust their voice. We need to engage those leaders and make them part of this important work in suicide prevention. And I know many of you are those leaders as well. Next slide, please. The second strategic direction is around treatment and crisis services. Goal 8 is implementing effective suicide prevention services as a core component of healthcare. I think about in Oregon, all the different systems that have taken on zero suicide. And these are both healthcare systems and community mental health systems. And the difference that makes in terms of suicide prevention and intervention really being attended to in a healthcare setting is phenomenal. We have been conducting a whole series of interviews with medical care providers across the state, and two very strong themes are emerging from those interviews. One is that doctors and nurses are increasingly expected and needing to be behavioral health support folks for people coming into their settings. We all know there's a behavioral health workforce crisis in Oregon and across the nation, really. And what I hear again and again from doctors and nurses is that either they feel they are not adequately prepared or they feel their colleagues are not adequately prepared to identify suicide risk, and more importantly, to actually talk about with their patients ways forward when risk is identified. There remains a lot of stigma and a lot of fear in this area. And so looking to the systems across the state that are implementing zero suicide, I think is a really important thing for us as a state to be doing, because those systems take a look at not only how you do broad messaging, but how you actually integrate it into these complicated worlds that the healthcare systems are. So it gets into the screening, it gets into referral processes, becomes part of the everyday vocabulary. So as I look at goal 8, I really see those two words, core component of healthcare. And I think, why shouldn't it be? We're talking about saving lives in the same way that CPR saves lives. And we're losing almost 50,000 people a year to suicide. It absolutely should be a core component of healthcare provision. Goal 9, improve the quality and accessibility of crisis care services across all communities. So goal 9 points to 988. Yes, that's crisis care response, but it also is referring to the new investment there has been in mobile crisis response across the United States and here in Oregon. We know that there continues to be huge needs for investment in this area, and it's a system that is being built as we talk, but every part of Oregon now has a 24-hour crisis response team that can be called if a family is in real mental health crisis. I don't want to oversell anything. I know that this works imperfectly. I know that it can be very challenging in rural communities, for example, to get across long distances to people who are in crisis. I think we all need to be part of building this infrastructure and supporting it, and honestly telling our political leaders how important investing in this mobile crisis response in partnership with 988 is. Strategic direction 3, I'm not going to spend as much time on, partially because I want at some point to have our partners at universities and colleges come talk to us as a community a little bit about what they see as needs moving forward in this area. But we know that we want to improve the work we do over time and understand what we are doing that's working well and what isn't working well. And that's what they're talking about when they're talking about surveillance, quality improvement, and research. Goal 10 is really about improving the quality and timeliness and scope of data. And look at that very important word, accessibility. Ensuring that those of you working on the front lines, working directly in communities, have access to meaningful data in your about your community to help you think about how to prioritize suicide prevention and to move it forward. And finally, there is a national goal of and commitment to promoting and supporting research on suicide prevention. And I know right here in Oregon, we have several different kind of centers of suicide prevention research occurring. There's the Suicide Prevention Lab at the University of Oregon. Oregon State University is very engaged with suicide prevention exploration. And at Portland State University, there's a department that's working very closely with public health around suicide prevention and assessing the various programs that have been funded nationally to come into the state of Oregon. Next slide. The final area or strategic direction is health equity and suicide prevention. And, you know, I think we all hear the word health equity, at least in Oregon, so often that it can be easy to kind of skip over that. And I just want to emphasize how incredibly important it is that nationally, this is being called out as an important element of thinking about the work of suicide prevention. Goal 12 calls us to embed health equity into all comprehensive suicide prevention activities. Goal 13 asks us to really think about populations disproportionately affected by suicide, with a focus on historically marginalized communities, persons with suicide-centered lived experience, and youth. And I just want to pause on that goal 13 to hear if there's any examples from around the state of programs that fit that goal. Well, I mean, I can think of a couple. Youthline, Sources for Strength, Latin and Spanish language, Big River programs, suicide prevention programs. James, who is one of, I believe right now, maybe the only person in the country that has the title Black Youth Suicide Coordinator, and there's now a Black Youth Suicide Coalition. Cultural infusion work with Dr. Choice Chu. It's really exciting to see kind of these new seeds growing across the state to try and have much more culturally specific and responsive work. Thank you for adding those things to the chat. Rosanna opened the meeting with us talking about the work that the tribes are doing across the state to have very culturally specific and integrated work as well. Goal 14 is around actually the workforce. So creating an equitable and diverse suicide prevention workforce that is equipped and supported to address the needs of the communities they serve. And the thing I want to highlight about this one is that many of us in here are the suicide prevention workforce. And it's really time for us to think of ourselves proudly as a field and consider recruiting people into doing suicide prevention work. I don't know about you, but I kind of got into suicide prevention work accidentally. And I have been so grateful for being part of this field. It's deeply meaningful work. It's about saving lives, but it's also really about going upstream and looking at how it is that we're interacting with each other, how we're helping people to find ways to be hopeful, how to build their resilience, etc. So let's think about this one as we're thinking about what young people are studying in school, as we look out to behavioral health programs in schools, and really continue to work and lean into efforts to increase information and accurate information about suicide prevention in those settings. And the final goal under health equity is improve and expand effective suicide prevention programs for populations disproportionately impacted by suicide across the lifespan, again, through improved data, research, and evaluation. We need to understand more about why different communities are disproportionately affected. And we also need to understand more about what the different communities need in terms of ongoing support to prevent suicide. Next slide. Just wanted to pause for a moment on health disparities and suicide and see if we could break up into groups of 4 and just take a moment to take a look at the conditions that contribute to increased suicide risk. And as a group, in your groups of 4, if you could take a moment and just talk a little bit about how you may have seen that show up in your work, and if there's any way that you're trying to specifically address one of these health disparity issues in the work that you do. So we'll break into groups of 4, and Lines for Life. Late breaking news, Lines for Life received 48,348 phone calls in 2023. Phone, text, chat, all the different methods of connecting with 988, which is just phenomenal to see that level of support going out in the community. Thanks for that, David.
Annette, can you redo the prompt? Resay the
Yes.
prompt.
I will redo the prompt. The prompt is, please take a look at these health disparities. These are all things that contribute to increased risk of suicide. And talk about any way that you know, either in your workplace or life, that you're part of a program or an approach that is addressing these disparities in some ways, that are working to change and shift these realities. All right, Jen, if you don't mind breaking folks into groups of 4.
If you all would want to take a picture of this slide with either a screenshot or your phone, because I won't be able to transfer the slide. I mean, I could, yeah, actually, if somebody just wants to do that for your groups, that way you have it. And then the rooms are open. And Annette, if you, it's perfectly 4 per room if you join one. If not, one will only have 3.
I'll join. So Janet won't let you leave the slide.
What are you doing? You're obsessed. Hi.
Welcome back, everyone.
Whoa. Oh, sorry. Thought I was muted. I said that to my kid. And I'll mute embarrassingly. Okay.
No worries, Jen. All right. So let's go to the next slide. Curious in your conversations, if folks don't mind unmuting for a moment, and if you were able to share any examples, these are proven strategies to address suicide. And as you were thinking about health disparities, some of those factors within those health disparities, whether you had examples from around Oregon in any of these areas to address suicide or suicidality.
Annette, this is Rachel, and I'm going to apologize for my dog playing in the background. But child welfare is really basically everything that we're doing at this point in time is looking at addressing health disparities. But I did share with Lucina that we are actually in the process within our critical incident review teams, the CIRTs that happen when we have child fatalities. We have I just created a draft document that we're going to be providing to attendees who are the staff who are participants in those reviews when they come forward and talk about the circumstances of a fatality. that outlines multiple social determinants of health. We're asking them now to incorporate that conversation in the reviews. So instead of just looking at case factors and a family who's had a fatality, including suicides, we're now asking the district to be reporting out on what these look like. Do they have equal access to healthcare? Do they have equal access to healthy food? Do they live in walkable neighborhoods? Do they have access to stable housing? Those kinds. So when we're looking at these fatalities, we're actually going to be assessing social determinants of health and then making recommendations for the broader system on how to address those disparities moving forward. So we're going to have a better picture of what's happening for families that very specifically addresses social determinants in our fatality reviews.
Rachel, thank you for sharing that. That is such a powerful example. And it's another example of how postvention, so if you think about it, child fatality review boards, which are looking at childhood deaths, some of which will be suicide, that understanding the factors that came together to lead to the death of this young person really is important as we think about how we're going to address and prevent those issues coming forward. So thank you for highlighting that, Rachel. I also think the fact that our child welfare system has somebody with Rachel's position, which Rachel's the suicide prevention coordinator for ODHS, is remarkable and really speaks about the intersectionality of this work and the way we're doing some cross-sector work. Any other examples that folks had from their groups as you chatted about as you had this last conversation? Gordon?
There, I was trying to get my mic on. One of the things I think impacts many of these bullet points is messaging and getting the message out to people in their homes, over the radio, etc. And most of these could benefit from really looking at that, how to get it in to the people's homes so they've got a reminder.
Thanks, Gordon. I think that's one of the things that as a field we continue to work on and try and expand how we get these messages out. And it's an ever-changing landscape, of course, with social media, etc. So there needs to be multiple strategies to move out these messages of hope and resilience and access to help. Any other examples folks want to share? Okay. Well, I know you're all doing work in these areas, and as you plan for your coalitions, as you plan for your organizations, thinking about these strategies and how you can frame the work that you're doing within these strategies will help you as you work to sustain your funding and track your progress. Next slide. I wanted to include this slide, even though it's specifically thinking about healthcare systems and behavioral healthcare systems, but I think it's a useful phrase for us to be thinking about. So this is at the level of intervention. So a lot of what we've been talking about has been prevention, but at the level of intervention, how do we intervene and support people in a way to prevent suicide? And this is literally a map of the process that you can go through that starts with concern being identified during routine appointments. Again, getting back to that concept of it being a core part of health and behavioral health services. And having some of the skills for evaluation and being able to identify, does it need to move up to a higher level of care? So using screening effectively, using one of the evidence-based tools. And then if risk is identified, having a pathway to a full clinical assessment using an evidence-based tool. And even if there is no immediate or imminent risk, I think this is something that's very important, that we still think about providing some resources around suicide prevention so that they can be connected up to collaborative safety planning, that they can learn about lethal means safety counseling. I think one of the goals that we really have is that it becomes a standard part of medical practice for people to assume that someone has a firearm in their home and talk to them about safe storage of their firearms, since we know that more than 60% of Oregonians own a firearm, last I heard. This becomes absolutely essential. Let's see. Thanks. Connecting with evidence-based treatment and connecting with peer support. Again, this is speaking to the power of lived experience and people walking side by side together, continuing to ensure that our peer workforce in Oregon is well prepared for handling people handling it when people are thinking about suicide, helping walk them through the system. And the final piece of the suicide care pathway is really having a process in place to kind of review the progress. Did the suicide care that we provided make a difference, that made a difference in these people's lives? I would love to look forward to a time when in Oregon, across the state, we said in every healthcare system, in every behavioral healthcare system, the folks who are leading those systems can clearly articulate to you what the suicide care pathways are for somebody who's struggling with suicidal ideation. And not only the leaders, but everybody from the receptionist to the doctors understands the role that they can play within those suicide care pathways. Next slide. This is a chart of risk factors and protective factors. We actually started by talking about protective factors at the beginning of this webinar. And I just wanted to take a moment to have this up on the screen just to show people these are the risk factors, the ones on the left column, that are, it's not exactly a one-to-one, this risk factor will impact that protective factor. But what we know is the risk factors are part of the kind of thorny complexity, that suicide is not a single issue problem, that there are many different things that lead to the knotty problem of suicide, and that we need to have comprehensive and integrated approaches to move the work forward. Next slide. And with that, I will close the meeting and thank people so much for coming. Really appreciate you being here. I included a very professional picture of Jen because she deserved that, and a very silly picture of me because I think silliness is an important protective factor that does not get talked about enough. I'm going to stay on for the next 10 minutes in case anybody wants to stay on and talk about things, comment. If there's any thoughts folks have after getting a quick orientation to this framework. And otherwise, if you are ready to go on to the rest of your day, you're welcome to do that as well. And we should turn off the recording.